Thank you. Thank you, Karen. What if I told you that understanding health information could mean the difference between independence and struggle, between hope and helplessness? Health equity is about making sure that every person anywhere in the world has a just and fair chance to living a life as healthy as possible. But for our patients with neurological conditions such as stroke, epilepsy, dementia, or Parkinson's, the chance is often out of reach. Why? Because our healthcare systems are designed for those who can navigate complicated instructions, who can speak clearly, or can advocate for themselves. But what happens when the very condition one is affected with impedes all of this, their memory, thinking, and speech? I saw this firsthand when working with a group of patients with high stroke risk factors in Calcutta, India, as well as with a stroke community advisory board at Mass General. One patient mentioned that they did not understand the diagnosis of stroke well into the treatment plan because it was not explained to them in a language that they understood. Another patient mentioned that they went home with a very thick discharge packet full of notes, but could not comprehend any of it because the cultural context was missing. So, what happened? They didn't follow through the care plan and ended up with another stroke. Another patient mentioned that they kept switching doctors because there was absolutely no way they could understand what the recovery plan looks like for them. What about caregivers? There was one singular resounding message: we were confused and alone. While these stories may seem emotional to you, they're educational. They are data. Data that tell us exactly where the health systems are failing and how we can fix it. One of the biggest challenges, health literacy. So, what is health literacy? Health literacy is the ability to find, understand, and use health information. It's not just about reading levels. It's about being in control of one's health and well being. Because when patients and caregivers understand their health and its consequences, they're compliant with treatment plans. There are lesser complications, there are fewer ED visits. Without this understanding, even the best care plans will fall through. And for neurological patients, when their communication and cognition are so deeply affected, the burden is even heavier. So the question arises, how do we lighten this burden? One powerful solution is organizational health literacy. It's when healthcare institutions take the onus and responsibility to simplify health information, make it accessible, and tailor it to the needs of the patients and caregivers. It's important to remember that when communication is easier for our patients and their caregivers, the burden is lighter on the systems and the healthcare providers. Now imagine a patient goes home with a discharge packet, but not like before. It has short sentences in a language that they can comprehend with audio and visual aid. Or a caregiver has access and information of support groups as a routine part of care, or where insurance and follow up care are being explained with real life examples. But none of this works if we are not listening, and that's very key to our understanding here. Too often, healthcare plans are designed without asking patients and caregivers what is it that they need. Community based participatory research, or CBPR, flips that. We don't start with assumptions any longer. We start by asking the communities we serve and we listen to them. With the help of that, with CBPR, we build better communication tools, better treatment plans, and more human centered care. If you're thinking this is the first time that I'm talking about CBPR, it's not. It's actively being used in US and worldwide. In Detroit, a stroke campaign used local voices, music, and even storytelling to teach communities the signs of stroke and speed up emergency response, saving time and lives. In Wisconsin, clinical and academic partners teamed up with local Black voices to teach caregivers in dementia care how to best support their loved ones, to build research collaboration, and to strengthen trust. But all of us here can agree that research alone doesn't save lives. So now that we have all of this information, what do we do with this and how do we do this? This is exactly where implementation science comes in. Implementation science is the science and art of making sure what we know is being implemented or used and delivered in settings where it matters the most: clinics, hospitals, and the communities we serve. During my postdoctoral fellowship under the mentorship of Dr. Nirupama Yechur at Mass General Hospital and my master's in public health at Brown University, I learned how to use these three elements: health literacy, community engagement, and implementation science to advance health equity in neurological populations. This is at the heart of my work, putting lived experiences where it matters the most, right at the center. Because when we start treating lived experience as expertise, we get it right the very first time. And when we get it right, magic happens. The patient is no longer confused about their diagnosis and recovery plan. The caregiver is no longer bearing the entire weight of the system on themselves. And you ask, what about the healthcare providers? Well, they get to do what it actually means for them to do: caring and healing, not re explaining paperwork over and over again. It's important to remember that health equity isn't just about fairness and justice. It's about access, it's about empowerment, it's about dignity and transformation. And that's why my research matters. But what matters even more is the way it's done, how it's done, because it needs you in it for the communities we serve. Thank you so much.